These are really important things that an oncologist is never going to tell the patient to do. Hyperglycemia and hyperinsulinemia is associated with much greater, sometimes 2 to 3 to 4-fold higher incidence of cancer. But if we had a drug that did this, it would be a blockbuster for sure.
Dom, let's jump right in today and talk about why the ketogenic diet is such a therapeutic way of eating when it comes to prevention and treatment of cancer.
Yeah, I am glad to discuss this topic. It's a topic that got put on my radar by someone I think you know very well. You've had on the podcast, Dr. Thomas Seyfried, who published an article in 2008 on a calorie-restricted ketogenic diet in an animal model of brain cancer. And that caught my attention because I was looking at anti-seizure effects of the diet and also was doing some work at Moffitt Cancer Center at the time. And really appreciated that cancer was, at the time in 2008, had a metabolic component that was grossly kind of underestimated and not really appreciated from the standpoint of targeting as a metabolic therapy. So there are various imaging technologies like FDG PET scan that was used to image the aggressiveness and the location of tumor, and that's a metabolic phenotype, but that was not being used to actually target the cancer. So that sent me down a path to understanding cancer as a metabolic disease. And I would say I was not swept away by what Tom Seyfried was putting out there initially, but when I started fact checking him and actually reading all the literature, I realized that this is a path I think I wanted to go down. And I had a student at the time, a Ph.D. student, a fresh Ph.D. student in the lab, Dr. Angela Pop. And she nudged me to go down that direction because she wanted to do her PhD dissertation on this topic. So that was, I got to look at the calendar here. That was 15 years ago. So that sent my trajectory down, looking at the ketogenic diet and metabolic interventions as an adjuvant to cancer therapies. But also, the more we delved into it, we realized that this was a potential preventative strategy. And now we've, partnered with different people who are kind of advancing that front too.
You use the term there, cancer as a metabolic disease. I think to really appreciate the impact of the ketogenic diet and some of the other things we're going to get into, it'd be helpful to talk about what that means.
So I know Dr. Seyfried probably went into this ad nauseum, but when I lecture to the medical students or just kind of give like a summary of my research to like faculty who are unfamiliar with it, I start from a very basic kind of understanding is that the mainstream understanding is that cancer is a genetic disease, and then alterations at the level of the nuclear genome, alterations in DNA function, and now we know epigenetic regulation and various mutations can trigger the activation of oncogenes at the level of the nuclear genome. And the nuclear genome, I guess stated another way, the fidelity of the nuclear genome in regard to DNA repair is intimately linked to the bioenergetic state of the cell. And what that simply means is the cell produces energy in the form of ATP. And when ATP levels, like when we're young and healthy and our mitochondria are very robust, we make sufficient amounts of ATP, and all the corresponding signaling pathways associated with robust mitochondrial ATP production are up to par. But when ATP levels fall, that signals a mitochondrial dysfunction. And there's a retrograde response at the level of the nuclear genome that senses an energetic crisis, right, from impaired mitochondrial function. And this could be due to oxidative stress, aging, inflammation, a wide variety of environmental toxins can do this. And it's a failure of the mitochondria and an overproduction of oxidative stress that then triggers the activation of oncogenes, which could essentially the carcinogenesis oncogenic response, right? The transition of a normal healthy cell to a cancerous cell. And but it starts, the important thing to appreciate and acknowledge and to further test and validate and validate this theory is that it kind of starts with at the level of the mitochondria. And I'm just speaking, I'm making it very simple and speaking at the level of the mitochondria making energy. But the mitochondria is an organelle that does so many different things. And our lab actually studies the redox control and how the mitochondria control redox levels, and the mitochondria are a source of neurotransmitters. So as a neuroscientist, I study, for example, monoamine oxidase, is produced in the mitochondria and a wide variety of neurotransmitter systems. But when we're talking, if we get to the essence of the metabolic theory of cancer, it dates back to Otto Warburg, where he posited a theory that dysregulated mitochondrial function, stated as insufficient respiration, leads to compensatory fermentation. So respiration, we're not talking about breathing, we're talking about oxidative phosphorylation. When that process is impaired at the level of the mitochondria, there are compensatory mechanisms that are very robust in cancer cells. This observation was made where the cancer cells default to an energetic pathway to derive energy from fermentation, or substrate level phosphorylation is a kind of scientific term for that. And that would be the metabolism of glucose and glutamine to preserve the energetic state of the cell, simply because, and this is what the metabolic theory says, simply because the mitochondria are altered in a way. The metabolic theory says they are dysfunctional and they are, lacking.
If you want to learn how to implement the ketogenic diet and the Press Pulse protocol into your cancer management, just visit school.com/keto for cancer, the new community by our research analyst Johnny Rockermeyer. Within this new community platform, you can connect with other patients and learn from their experiences. You can also just search through the posts other members have already made. You will have access to our classroom section as well, which provides practical advice and tools for the best results. These sections cover all parts of the Press Pulse protocol that you should implement. Starting with the general scientific concepts by Dr. Thomas Seyfried, we will show you how to start the ketogenic diet, including which foods to choose and which to avoid. Additionally, we prepared a list of doctors specialized in metabolic therapy, as well as details about glutamine inhibition and hyperbaric oxygen protocols. So, take a look around at school.com/keto for cancer.
Mainstream, and it's important to acknowledge this, that mainstream cancer biologists would say the Warburg causes a shift in the mitochondrial function to endow the cell with the capacity for biosynthetic production. So various intermediates are then shifted to biosynthetic pathways, for example, to make lipid membranes and things like that. So the Warburg is an advantageous effect for the survival of the cell, where the metabolic theory is like the initial hit to the mitochondria alters the retrograde response, and then that kicks on the oncogenes. So the mitochondrial function becomes the driver for cancer. And stated another way, and Tom Seyfried kind of coined this term, healthy mitochondria are the ultimate tumor suppressor. So, and I think that's a theory that still needs to be studied, that if we have healthy, robust mitochondria, is it possible for a normal cell to transition to a cancer cell that has all the hallmarks of cancer? So that's a very provocative question, and we don't have an answer to that yet.
Oh, that's a great breakdown, and a lot we can get into from there. You've stated clearly at the root of all of this is dysfunction with the mitochondria. And now I want to tie this into the diet piece from a prevention standpoint. So we'll talk about the ketogenic diet. How does that support the mitochondria in prevention? And then we'll get to treatment later.
Okay. It does it through a number of ways. And the optimal diet for cancer prevention may not be the ketogenic diet. For some people are, in particular, people who are obese, type 2 diabetic, overweight. It's a very effective way to get insulin under control. And when we suppress the hormone insulin, that activates metabolic machinery to increase our fat oxidation capacity and our ability to make ketones, and actually limits or marginalizes glucose as a fuel source. So it makes us more metabolically flexible. And the standard American diet, eating multiple, high carbohydrate meals throughout the day in and day out, largely suppress metabolic flexibility, where in the past, of course, we had limited food availability and we did not have access to the amount of carbohydrates we have now. So we were metabolically flexible in the past, and it's debatable, but maybe that's why we didn't have the high rates of cancer way back in the day. Or of course, we didn't have the diagnosis and imaging technology to diagnosis. So people just died for unknown reasons. But I think even epidemiologists agree that, cancer is a disease that is far more common today than it was in the past, right? So I think that's important to appreciate. A ketogenic diet kind of brings us back to our evolutionary past, in that by eating a ketogenic diet macronutrient ratio that's high in fat, sufficient and moderate in protein, not high in protein, and the carbohydrate source is largely fibrous carbs from vegetables. So you have fat, adequate protein, and fiber. And this diet suppresses the hormone insulin, which is a really important component in regard to cancer outcomes. And it also reduces blood glucose levels, some extent, not too much baseline glucose, but it does it reduces the glycemic variability. So, or spikes. And actually those spikes in glucose are triggers for other pathways, other growth factor pathways. Like when you could have a normal baseline glucose, but if you have a periodic spikes in glucose, it's releasing insulin, and that relative change in glucose then is the driver for releasing insulin, which can then augment and change IGF-1, mTOR, and other pathways associated with cancer growth. So a ketogenic diet really takes the foot off the gas pedal of cancer growth, if you have it, and it actually produces an environment that makes it less likely that cancer would grow or even initiate. That's what we believe, and I think if you go back to the calorie restriction studies, this was seen. And I think an important thing to acknowledge too, that if you have any diet and you reduce calories, or you do it intermittently, and you control insulin, you control glucose, and you keep insulin, or you keep inflammation low, those three things, I think it would be very similar to the cancer suppressive effect of a ketogenic diet. So you could do that with any diet. The advantage of a ketogenic diet is that it likely makes it easier to adhere to caloric restriction, which can be very helpful for many patients. Also limiting that glycemic variability, reducing insulin a little bit more, and then you have the production of ketones. So the liver produces ketones, but can't use ketones as an energy source, lacking succinyl-CoA transferase, unless you have like liver cancer. So the liver is almost like an endocrine organ that's releasing this, fuel that the body's using, this endogenous metabolite that is not only providing energy, but it has its own receptor, GPR109A receptor, as an example, and that can trigger a reduction in inflammation. It has epigenetic effects through histone deacetylase inhibitor enzymes. It directly interacts with the histone via beta hydroxybutyrylation, which is a whole pathway a graduate student of mine is studying right now. So not only is it an energetic fuel that can increase ATP production per unit of oxygen, perhaps even 20% higher ATP production. We know that's the case with the heart. No one has validated that in the brain or muscle, but cardiac muscle they have. So you have a fuel that is more bioenergetically favorable when it's metabolized. It produces less reactive oxygen species. And then it also functions in a way that can increase our antioxidant capacity. It has favorable epigenetic effects, and it changes various signaling pathways that would favor a suppression of cancer growth. So that's the advantage of the ketogenic diet. But, taking a big step back, if we just focus on our body composition, if we, keep a healthy weight, if we stay active, exercise, maintain strength and vitality with any diet, that's probably the most important thing. But the ketogenic diet is kind of like the icing on the cake. And when we talk about a ketogenic diet that puts your glucose ketone index within the range of like 1 to 3, then that is what I call a prescription ketogenic diet. There's like the internet ketogenic diet, right? And then there's the prescription strength ketogenic diet. And that's a highly calculated ketogenic diet that needs to be managed, that keeps your glucose ketone index, which is the ratio of your glucose over ketones in millimolar concentration, that ratio between 1 to 3. And that in and of itself has incredible anti-seizure neuroprotective effects, but will have tremendous tumor suppressive effects, and would further augment the therapeutic efficacy of standard of care therapies, including radiation, chemo, and immune-based therapies like checkpoint inhibitors, PD-1 inhibitors, for example, would be augmented by that metabolic state.
You quickly touched on the fact that this diet could help with seizures, and it gets me thinking about the fact that what we're talking about today, we're directing it at cancer, but this diet has so many benefits when it comes to you follow this down and it fixes the metabolic health, which is related to so many of the chronic health conditions. So again, we're
Yeah.
taking this lane of cancer, but it applies to so much more.
Yeah. So we call this it's multifaceted pleiotropic effects, right? So and that makes it very difficult to study too. A lot of people ask, well, what's the difference between a ketogenic diet and just giving like exogenous ketones, which is another topic. It's like a hack really to lower your glucose ketone index. And similar to giving a fuel like exogenous ketones, when you alter metabolism and shift the metabolic machinery and also the fuel that it's using, you are changing so many different downstream pathways, and it's hard to disentangle and identify specifically what is favorably changing, and that might be different depending upon the person. One person may have an insulin level of 20, right? And a ketogenic diet may bring it down to 5 or 6, and that's beneficial. Another cancer patient may have a normal insulin of 4 or 5, but they may be benefiting from, the higher ketone levels and maybe the anti-inflammatory state of that. So it's hitting many different. If we had a drug that did all these different things, and I mean, the closest thing that we have is maybe metformin, and there's some side effects to that, right? But if we had a drug that did this, it would be a blockbuster for sure. And I think that's important to acknowledge that from the context of people asking, well, where are the human, randomized clinical trials, which we do have for epilepsy, but where are the RCTs for cancer? We have quite a few pilot studies show it's feasible and that it's efficacious under some conditions. But they still, doing nutrition research is incredibly hard. I was talking with Dr. Jeff Volek yesterday, who's like a pioneer in this. Actually, he's doing quite a bit of cancer research. So it's just hard to do this kind of research. And but if you go to clinicaltrials.gov, and people listening to this can just go to clinicaltrials.gov census.gov and type in ketogenic diet and cancer, and you'll find at least 3 to 4 dozen clinical trials for cancer. And 10 years ago, there may have been 2. So it's very reassuring that this has been put on the radar. There's even some federal funding supporting it, but it is not purely a non-toxic metabolic therapy. So what institutions are doing or pharmaceutical companies are doing are actually using the diet to further enhance and augment specific drug therapies. That could be the case for metabolic drugs too, like PI3 kinase inhibitors, for example. So I think Dr. Lou Cantley kind of spearheaded this class of drug, which on paper, I mean, these seem to be remarkably promising, the idea of a PI3 kinase inhibitor. But when you administer these drugs, there's a counter-regulatory effect that causes your insulin to surge. So the elevation of insulin associated with PI3 kinase inhibitor drugs then negates the effect of the drug by itself, because insulin can enhance cancer growth by increasing glycolysis and other growth factor pathways. But in the context of a ketogenic diet, a PI3 kinase inhibitor, then you sort of unleash the beneficial effects of a PI3 kinase inhibitor in the context of insulin suppression through a ketogenic diet. And a lot of high-level investigators that are publishing papers on ketogenic diets, and they don't even put it in the title. They'll say like insulin suppression therapy plus drug X, improves cancer outcomes. And you look at like, what's the insulin suppression therapy? And I'm not going to mention names here, but it could be, in one case metformin, but insulin suppression therapy is a ketogenic diet, but as cancer researchers federally funded, there's a stigma to the diet. And that actually prevents a lot of people from talking about it, I think. And I've never been shy to talk about it, but I was a neuroscientist physiologist that kind of stepped into the world of cancer. So I viewed cancer as something that was very difficult to understand. I think it still is. But when you approach it from the context of like a physiologist and cell biologist, it started to make more sense from the perspective of a metabolic component. And there's a lot that I don't understand from a genetic and epigenetic standpoint. But what I do know is that there's a grossly underappreciated metabolic component of cancer that has been utilized by an FDG PET scan, but that metabolic component has not been leveraged, or targeting it has not been leveraged from a therapeutic standpoint. So that was the case in 2009 or 10 when I started studying it. It's still the case now, but it is actually ramping up to where now there's actually conferences on cancer metabolism focused on these pathways.
We've gone over quite a bit already and gotten into a lot of nuance, which is great. I just want to try and tie some of this together for people. We started off saying that the metabolic theory states that the origin of cancer is dysfunction with the mitochondria. And when we got into the ketogenic diet, we talked about how that helps with inflammation, helps regulate insulin and keep that down or keep that more balanced. How do those tie together? So when it comes to inflammation and insulin tying to the mitochondria, like we opened up, is there a connection there?
Yeah, well, if we look at epidemiological data, and that's not always the most reliable data, especially in nutrition, but if we look at epidemiological data, it's very clear that higher blood glucose or hyperglycemia and hyperinsulinemia is associated with much greater, sometimes 2 to 3 to 4-fold higher incidence of cancer. Right. And the hyperglycemia and hyperinsulinemia is associated with an elevation of even systemic inflammation like CRP or high sensitivity CRP, C-reactive protein, or certain inflammatory cytokines. And that metabolic dysregulation creates fertile ground for a transformed cell from a healthy cell that has transformed into a precancerous cell to take root and then proliferate and grow. And then as that tumor grows, it becomes larger. And as a tumor grows, the core of the tumor, as a tumor grows, it outstrips its ability to supply blood and oxygen to it. So this is like the core of the tumor. And then the tumor, the mass of cells that then become a tumor becomes even more genetically dysregulated with more mutations occurring from the hypoxia at the core of the tumor. And the hypoxia further damages the cells of the tumor, and it becomes more aggressive, right? So and then as it becomes more aggressive, then it starts meeting all the hallmarks of cancer, right? You have, insufficiency of, growth signals and immune evasion, and then most importantly, invasion and metastasis, where clumps of tumors can come off, they get in circulation, and then they seed, for example, in the liver and the kidneys and the lungs, and then they become metastatic. So most people don't die of a tumor per se, unless it's maybe a brain tumor, but people die of metastatic cancer. So actually the model that we used is an excellent model of cancer because it's a highly aggressive model of metastatic cancer. And this was developed by Thomas Seyfried. And it's a unique model, the BMM3 model, because the primary tumor was a brain tumor, glioblastoma, but we use an inbred strain of animals, the VMDK mouse. And when we take these cells out, dissociate them, plate them, grow them, and implant them into the flank, then you have very rapid systemic metastatic cancer, and becomes a very powerful model. And it also features cancer cachexia and muscle wasting, which is termed cancer cachexia. That's a unique feature of the model. And one of my PhD students studied that. So that's the features of cancer that could be targeted by a protracted ketogenic diet, not only a ketogenic diet, but a diet that's low in carbohydrates, a diet that moderates calories in a way that optimizes metabolic biomarkers and cardiometabolic biomarkers that produces a physiological state that would make it less likely for cancer to occur. I mean, that's the most we can do, right? I mean, some people are just unlucky. I have communicated with people who are elite level athletes, people that had great metabolic health on the surface that got cancer. So this challenges in many ways the metabolic theory. But when you talk to them, they're like, oh, well, I have, had Epstein-Barr virus, or I had, some kind of viral hit, or I was exposed to some kind of toxin. And it's kind of unfortunate because they believe maybe there's some things that they did that caused the cancer. And that's, I think, kind of unfortunate. But I do think that some people are just unlucky. And they could have a pre-existing gene, a SNP, or an environmental hit or toxin that, triggers an oncogenic shift and triggers a tumor cells to grow that form a tumor. So, and then the case with childhood cancers too, like they really haven't lived long enough to be metabolically dysregulated, to have poor metabolic health to get. So there's a lot of, I could see there's a lot of ways we can challenge the metabolic theory of cancer, but I think what's important from my perspective is that a rapidly growing tumor is highly glycolytic and is fueled by high glucose and high insulin and glutamine. And we have tools that we can target that. And also from the perspective that, I mean, it's appreciated now, right? I wrote the foreword to Travis Christofferson's book. And I really kind of delved into Tripping Over the Truth, and he would be a great guest to have on if you haven't. So in Tripping Over the Truth, that forward really just kind of delves into metabolic health, why it's important, and why a wide range of cancers are are increasing due to poor metabolic health, and why we need to target that.
Well, let's
So
take that part of the story now and run. So, somebody has cancer. You've touched on the glutamine, glucose, the two fuels that we want to target. You've also talked about ketones, and I'm curious if you've come across any research showing that cancers can be fueled by these. Let's start off with that.
yeah, I do think that some cancer cells can use acetoacetate and maybe beta hydroxybutyrate and ketones uh, for biosynthetic production of lipids, and I think that's possible. I think more indolent cancers can maybe use fatty acids for fuel. So by indolent, I mean like kind of slower growing tumors like prostate cancer or things like that. However, the more aggressive and the more metastatic a tumor is, the more glycolytic it is, and the more a a fundamental feature of that cancer, if you were to cut out the tumor and do an electron microscopy, the structure of the mitochondria would not look normal at all. The cristae would be almost absent or dysregulated. The mitochondria may look like hollow little shells without the inner mitochondrial membrane. So structure dictates function, and the more aggressive and glycolytic a tumor is, the less likely the mitochondria are serving in the capacity of ATP production. But that does not, they have other functions and could be biosynthetic processes and could and there's other functions associated with it, but it's less likely that they would be using fuels associated with oxidative phosphorylation, which are ketone bodies and fatty acids for fuels. Um, and that's pretty much, I don't know too many people that would even challenge that. They may challenge the idea that that cancer, many still do believe, and I think in the lab and in various model systems, the mitochondria have normal oxygen consumption, and in some cases, in some cancer cell lines, maybe normal ATP production to some extent, but that's more likely an artifact of the model. But if you were, for example, to do biopsies of aggressive metastatic tumors, for example, glioblastoma, this has already been done, you'll find that there's a significant decrease in the number of mitochondria and a tremendous change in the structure of the mitochondria, especially the inner mitochondrial membrane. So that would challenge the idea that cancer is using fatty acids and ketones as a major fuel source. So they need to essentially default to fuels that are fermentable. And that includes glucose, of course, but also some amino acids, including glutamine, maybe alanine too, but glutamine for sure.
Well, let's get into the nuances of what targeting those looks like. We talked about
Yeah.
the ketogenic diet. Makes sense. A diet like that is going to help bring blood glucose down and help bring insulin down. But let's get into the nuances. If somebody is in that critical state right now where they're battling cancer and they want to attack it by blocking best they can these two fuel sources that we know are part of the picture, what would you say?
Do everything possible to improve your cardiometabolic health. So you will be doing yourself a very big favor by incorporating a dietary intervention, a stress reduction intervention, and maybe even most important, and I haven't talked about it, in exercise, in aerobic exercise and strength training intervention. And when it comes to, when people who have advanced metastatic disease, they generally succumb to muscle wasting and cancer cachexia. And a big factor is the wasting of muscle, which limits their ability to their mobility. And then things go downhill very fast from there. So it's really important to build metabolic currency and also muscle as metabolic currency. So the first thing that I would do is, talk to your doctor, talk to your oncologist, ideally an open-minded oncologist who has an appreciation that the food that you eat and your nutritional status have profound implications on the outcome of this disease. So that's first and foremost. You need to have an oncologist who acknowledges that, appreciates that, and is going to support you. Because if you have an oncologist saying, don't do this approach, even if you're giving him papers, then that's going to create a lot of doubt in your mind. And what I've observed in just communicating with cancer patients over 10 years is that when certain patients, I mean, when they believe that the metabolic based theory is working for them, uh, that has a profound effect on the outcomes. And whereas, maybe other patients, and they may not be following through with all the different components of a comprehensive metabolic, based therapeutic approach, the outcomes are less favorable. It's super important so I would say that up front. And then, as you eliminate all processed carbohydrates, stick to whole foods, reduce glycemic variability, do standard CBC, CMP blood work, get your insulin measured so you know that. And if you're overweight, if your BMI is, 28, 29, 30, if it's up there and it's not muscle, of course, and you have some fat to lose, it's important to follow an approach where you create an energy deficit, a caloric deficit. So that caloric deficit is further going to suppress insulin, glycemic variability, and also reduce many of the metabolic drivers for cancer. Whenever you have surplus calories, those surplus calories aren't going to end up feeding the tumor. However, if you create an energy deficit and a caloric restriction, then that's just going to marginalize the fuel to the cancer. What's really important when you create a caloric deficit is to do some kind of strength training and ensure that your protein is adequate, ideally 1.5 to 1.7 grams per kilogram, to preserve lean body mass and, if you can, build strength and muscle while you're doing it. And these are really important things that, an oncologist is never going to tell the patient to do. At least the way that I'm talking about it and giving specific, guidelines in regards to that. But I think another important aspect is to work with, the next thing to do is actually to seek out a trained diet consultant and to seek out information. It could be Miriam Kalamian's book, Ketogenic Diet for Cancer. It could be different nutrition oncologists that I've worked with in the past. Beth Zupackini is very good. Denise Potter. You can look these people up, and they have been sort of the go-to people that have helped a number of patients. And there's an emerging amount of registered dietitians and consultants that work on this. And then to work closely with a consultant, or if you're educated enough to follow strict guidelines and to buy various monitoring off the shelf, commercially available in Walmart. I saw it the other day. Amazon, you get a Keto Mojo device. If you want to be fancy, you can get a continuous glucose monitor, but you want to be able to measure your glucose and your ketones and seek to get a glucose ketone index between 1 and 3. And that may be hard to do in the beginning. I mean, the standard American probably has a glucose ketone index of like 25 to 50. A low carb diet may push you down to like a glucose, low carb meaning 100 grams to 150 grams of carbs a day, maybe a glucose ketone index of 10. But when you get your carbohydrates down to 50 grams or lower, then you start to approach a glucose ketone index of 5. And then you can tweak things with a dietitian to maintain that therapeutic range. And there's very good data in animal model systems and emerging data in human outcome trials to suggest that a GKI of 1 to 3 is highly therapeutic. And not just for epilepsy, which is kind of my wheelhouse, but also for cancer.
And it's important to highlight the fact what we're talking about here is not bringing glucose down to zero. A lot of times, people in the
No, you can't
cancer
do
world,
that.
you can't do that. Even if you're water fasting, your body's going to make glucose and keep a stable level of glucose. It's going to be a lot lower than if you're having carbohydrates. But I just want to point out the fact is that we're looking at this GKI number and we're not just trying, because again, it comes back to the starve of glucose and glutamine. A lot of people in their head right away probably think about, how do I get my blood glucose down to zero? And that's not possible or something you'd want to do.
No, the there are very powerful homeostatic mechanisms that maintain your blood glucose within a very tight range. Even after I fast for 7 days, my glucose was like, 65, 70. So that is important. When you fast, you're liberating triglyceride from adipose tissue. The glycerol backbone can then be converted to glucose. Gluconeogenic amino acids can be converted to glucose. Uh, Lactate, if you're exercising through the Cori cycle, gets converted back to glucose. So your glucose may fall from 110, 120 down to half of that, to like 60 or 70 at the end of the fast. But I'm a little bit hesitant to tell people to fast if they have a normal body weight, especially if their BMI is kind of low. However, if someone has fat to lose and a high body weight, which is a large majority of people who have these metabolically associated cancers, do have quite a bit of weight to lose. And one thing that I see in many people that communicate with me, especially those that are overweight when they're diagnosed, when they go into remission or have like what's called no evidence of disease after the therapy, most of them that communicate with me are just they're doing the standard of care, but they're coupling it with metabolic, and some of them are not. And like I was communicating with a glioblastoma patient that went over 10 years. When she was diagnosed, she was pregnant with her daughter. And she unfortunately just passed away a few months ago. But her daughter was 11 years old, and she was pregnant with her daughter when she was diagnosed with a glioblastoma. She did not do debulking. She did not do chemo. She did not do radiation. She did a calorie restricted ketogenic diet, fasting, and hyperbaric oxygen, and then some plant-based compounds too, like, green tea and various other things, I believe. So, but we stayed in contact, and, it was sad to see that she passed away. But it's important for people to look at the literature depending on what kind of cancer they have, and to ask their doctor, show me the randomized controlled trials on this particular drug and the outcomes, not only extension of life, but overall survival. It's going to be important. And to appreciate that outcomes can be highly influenced by the health and vitality and metabolic state of the patient. And I don't think that is actually, and I'm in contact with some of the top oncologists in the world, and they don't approach nutrition like that. So the nutrition is approached to mitigate side effects of chemo and radiation. So let's just keep calories, let's get calories in the patient, and let's prevent as much weight loss as possible. So that's kind of like the approach, right? And also to prevent any kind of nutritional deficiencies. So some things may impact, certain vitamin status. Some things may dysregulate the gut microbiome. So there's like probiotics and things like that. But they don't approach it from the perspective of further augmenting the therapeutic efficacy or targeting the tumor itself.
And when you talk about augmenting therapy, you mentioned fasting. It gets me thinking about using that as a tool for somebody that is following at least a partial conventional treatment
Yeah.
and getting chemotherapy. Talk about how somebody can use that as a tool to go along with that to help that treatment become more effective potentially and to help with symptoms.
Yeah. I think the first person that I saw observed in the literature that was doing it was Dr. Adrienne Scheck, and she was at Barrow Neurological Institute. She's a great friend and colleague of mine. She would be great on your show. Actually, she was doing radiation in a GL261 model of glioblastoma, and showing that doing radiation therapy, temozolomide by itself, and then looking at tumor growth and then the death of the animal. And then she would do a ketogenic diet after the tumor implantation and the tumor growth, and then couple that with radiation or chemo, and seeing extension of survival. And then ultimately, when she was, she was tweaking the diet and settled on a dietary formula, she was able to cure cancer in this particular animal model that I don't think people have using chemotherapeutic drugs. When she coupled the ketogenic diet with radiation, and chemo, in some cases, she was able to basically put the animal into remission from this advanced high, and Dr. Seyfried would argue with the efficacy of radiation therapy as a therapy that would increase the overall survival in patients. That he may argue that, which he rightly so, and he's written papers on this, that it damages the microenvironment in a way that can feed the tumor. And I'm not going to argue against that, but I think in some cases, debulking especially can be very therapeutic, and certain targeted radiation therapies can be advantageous for some patients, I think. But that I think patients need to question their doctor, and then when we come to and that's radiation in and of itself without a ketogenic diet. So when you couple radiation with a well-formulated ketogenic diet, and you're working in the capacity of what's feasible with the patient, with their metabolism. Sometimes there's dexamethazones involved, and that can increase your glucose. But when you have a well-trained dietitian who knows the art and the science of doing this, they're able to adjust the glucose ketone index within that 1 to 3 range. And that largely mitigates many of the side effects associated with radiation, including reduces the inflammation, reduces the associated necrosis, and gets insulin and glucose and inflammatory cytokines. It reduces these things in a way where side effects are dramatically reduced. There's some patients that communicated with me that they didn't have any side effects at all. Like even with the dexamethasone, they could keep a glucose level, at 70 to 75 milligrams per deciliter, or close to 3 to 4 millimolar, and maintain that. And that would be the highest that it gets. I mean, these are, not all patients can do that. But, on the other hand, if they were not following a ketogenic diet and were just following the recommendations for nutrition, their glucose would be in the mid 100s, would be double that for sure. So that's having a tremendous effect on the outcome, but also the side effects. So the first thing we need to do is not eliminate the standard of care and just go. I mean, at least from a research science point of view, and getting this accepted into the mainstream oncology centers like the Moffitt Cancer Center, which, we collaborate with, MD Anderson and other cancer centers. It's true, they do make their money off giving therapies, right? They do make their money off giving chemo, radiation, and many cutting-edge immune-based therapies. And I do think there's a lot of potential for PD-1 inhibitors and other checkpoint inhibitors to synergize with a ketogenic diet. And when I say synergize, that would enhance the efficacy, but also reduce the side effects.
When we just got into that side effect piece and increasing efficacy, you focus mostly on radiation. I thought it was more chemotherapy, but it sounds like it's both.
Well, I mean, chemotherapy has systemic side effects, and chemotherapy is a carcinogen, right? So you're giving a poison to kill off, ideally, proportionally more cancer cells than healthy cells. But the problem with chemotherapy, obviously, is that when chemotherapeutic agents are delivered, they're toxic to your normal healthy cells, but that also includes your immune system. So your immune system has incredibly fast, rapidly dividing cells that maintain immune surveillance, right? And I think that's really important to appreciate that that when you compromise your immune system, a big part of getting cancer is failure of the immune system to recognize. And there's various killer cells and a whole host of cells that identify certain surface markers, and then the body can then neutralize and kill cancer. And that is largely abolished after you do several rounds of chemotherapy. And I think that's important to kind of acknowledge that could be one of the main side effects. And so a lot of times you have patients, so cancer is a disease of aging. As we age, we get more cancer. And you have like a triple whammy when it comes to muscle and function too, because you have age-related sarcopenia on top of chemotherapy-induced muscle wasting on top of cancer cachexia. So you have like three different things that are compromising your skeletal muscle mass, which is your metabolic sink, and creates metabolic reserve, but most importantly, creates your mobility and your ability to be independent. So all these things are kind of synergizing together to cripple the patient. So you have that going on, and then your immune system. So it makes the patient very weak. And I've seen like normal, healthy patients. I actually trained with a patient who was an elite level athlete, and that was very strong. I mean, we were doing almost the same weights and everything in the gym, and he was smaller than me, lighter than me. And he went through chemotherapy and was like, could barely pick himself up. He had, a very advanced cancer, the pancreatic cancer. And, so that is difficult to deal with. Not everybody will experience side effects. So my recommendation would be for the patient to talk to the oncologist and say, maybe appreciate the idea of giving less of a dose of chemotherapy and do more targeted radiation therapy, and to look in various different metabolic drugs that are out there. Would be, if they're open-minded about that. I mean, even things like metformin. I mean, obviously it's off-label, but if you go to clinicaltrials.gov, type in cancer metformin, I think you get like 200 clinical trials. So there's existing science and there's emerging science being done now to show that it could be a favorable adjuvant to different, therapeutic approaches.
When you talk about metformin, it gets me thinking about natural products that have a similar effect, such as berberine or cinnamon, to help manage blood glucose. How do you feel about those?
I think cinnamon's great. I'm like a cinnamon freak. I get like probably a teaspoon or tablespoon of cinnamon every day. I think berberine's very interesting and has a lot of potential behind it. I have experimented with dihydroberberine, which is in a product by Optimizers makes, and I used dihydroberberine, and it's a formulation with a few other things. And I took a dose of carbohydrates and had a CGM response before and after berberine, and berberine knocked it down, maybe 25%. I think berberine is great for people who are insulin resistant and have problems reducing their blood glucose. I'm also of the opinion, like, the less supplements and drugs you can use, the better, and use these things as tools. First, nail down your nutrition, nail down your exercise, nail down your stress can augment your immune system and metabolism. Get these three pillars under control, and then add in various things one by one, so you can fully understand and appreciate them helping you, but also some of the negative effects. If you just do a shotgun approach, then you don't know, there may be some beneficial things. If you're, start taking 5 things at once and you start getting side effects, you don't know what's giving you the side effects. And I think it's important to start with evidence-based supplements that, something like alpha lipoic acid could be very beneficial. That could reduce glucose excursions with carbohydrates if you're on a carbohydrate-based diet. Things like turmeric could be used for cancer prevention. I mean, these things have anti-inflammatory effects, maybe protective mitochondrial effects. So I think from the perspective of cancer prevention, there's a lot of plant-based compounds and supplements that could be used. But even things like, the supplements that I use that could be beneficial, like creatine monohydrate. If you go to examine.com, there's like a number of studies on creatine and cancer that, you have favorable outcomes, people using creatine. It's super safe. It's the most studied nutritional supplement in the world, and it can increase your strength and preserve muscle strength and function, throughout your therapy. So there's simple things like that that are cheap, that are safe. Cancer patients have no idea. The cancer patients going to the major centers have no idea, probably never heard about creatine monohydrate. And, it's a simple supplement you can get anywhere that can have a noticeable effect on your strength and preserving muscle mass and cancer outcomes. There's research behind this.
Any other supplements while we're in this topic that would be good for people to consider, whether they're treating cancer or being preventative?
Yeah. Well, if you're following the ketogenic diet, carnitine is a good one. I like to use acetyl L-carnitine. It crosses the blood-brain barrier. That's a good one. Magnesium is excellent. Magnesium's involved in hundreds of different biochemical reactions. Most people are deficient in magnesium. So that's an important one. It's really important to keep your electrolytes up. And this took me a while to appreciate, but calcium, I was under the impression, I used to take a calcium supplement, and then, there was some some papers that came out to suggest that calcium may not be a good thing to supplement. But when you have calcium in your arteries, that's like more of a side effect of what your body is doing with the calcium. But what I've observed, and when I went, I've learned from the paleo community, but also in the farming community, is our soil is highly deficient in calcium. So very deficient. I mean, it's, part of fertilizers and things like that. So calcium's super important. I would recommend that at nighttime, different forms of calcium, magnesium, actually I use a ketone salt product, Keto Start. It's by Audacious Nutrition, and it has beta hydroxybutyrate that's spread out across the electrolytes. So you have sodium, which you really need to get sodium. Some of the carnivore people say 20 grams of sodium per day I don't know if you need, sometimes I get that much because I'm in Florida and I sweat a lot. So sodium, Keto Start has beta hydroxybutyrate ionically bound to sodium, potassium, calcium, and magnesium. So you get a balanced electrolyte. The electrolytes are really, really important. So calcium can also bind things like oxalates and help your body kind of eliminate them. But most importantly, I think calcium is a really good buffer in your blood and reduces acidity. So you have monovalent and divalent cations are like super awesome buffers, and they help eliminate some, plant toxins if you are eating salads and things like that. So are beneficial. So beta hydroxybutyrate salts, Keto Start is the one that I use. MCT oil, I use a product called Keto Brains, which is alpha GPC, MCT oil, theanine, and lion's mane. So, I mean, I just like that product. It gives me a good buzz when I'm writing. But other than that, vitamin D, if you're not getting a lot of sun, and K2. And then I eat a ton of fish, mackerel, sardines, and anchovies, which I stay low on the size of the fish to reduce heavy metals. I eat massive amounts of fish, pounds of fish per day prior to getting blood work and doing a hair analysis. And my heavy metals tested to be like in the low end of normal. So that was very reassuring that the type of fish that I'm eating has a very low toxin amount. So I looked at everything and did several tests. And so if you're not eating sardines, mackerel, anchovies, or just salmon and fish in general, I think it's really important to supplement omega-3 fatty acids, because these have been shown in clinical trials, a lot of animal work, to have an anti-catabolic effect. Some cases an anabolic effect. So they help not only reduce inflammation, actually they may have an anti-catabolic effect by reducing inflammation. So so I add omega-3 to the list. I said I'm not a big fan of supplements, but it sounds like I'm saying a lot of things. But I do think that that's kind of like that's what I take personally. And then I think that patients should probably get a workup, like Genova Diagnostics is a great company where you can get, tests done to look at your nutritional status. And then from there, then you could decide what you need. So it's not a good idea to supplement high dose of B vitamins if you're not deficient in B vitamins, because high doses of B vitamins could actually fuel cancer in some cases. That's a controversial theory, but and also vitamin B1 or thiamine may be deficient in some people. So that's another one, especially if you're taking some drugs that we've worked with in the past, like dichloroacetate. It activates pyruvate dehydrogenase complex, which then can make your body deficient in thiamine. You want to take, if you do that, you want to take alpha lipoic acid and thiamine to help, fuel that reaction. So it's kind of depending upon the therapy that the person is taking, but I'm not a big fan at all at megadosing vitamins or certain supplements. So strategic implementation of things, ketone salts, calcium, sodium, magnesium, these things are really important. And MCT oils, these things can help lower they kind of hack your GKI, if you will. Now, I get a lot of questions because most of our research has been published on ketone esters, right? Ketone esters are exogenous ketones that are very powerful, and they have anti-seizure effects. They also have anti-cancer and anti-catabolic effects. So a lot of what we've published have been ketone esters simply because that was what was available back then. Also, animals are hard to get into ketosis, so you have to use these very powerful ketone esters to really induce and sustain ketosis. I worry a little bit about administering a high dose of the ketone ester because it could potentially reduce your body's ability to make ketones. And it's doing that by virtue of an elevation of insulin. So the ketone esters do this. So we work with 1,3-butanediol acetoacetate diester. We've worked with 1,3-butanediol beta-hydroxybutyrate monoester. We've worked with a glycerol triester of acetoacetate and beta-hydroxybutyrate. So you don't need to know the terms. Just understand that I'm of the opinion, even though I've published on it, I'm of the opinion that ketone esters are not ideal for the metabolic management of cancer. I think we still need to do research on them, and I think they do have real side effects. We've killed animals administering ketone esters. That said, I do think they have incredible capacity when the safety studies are done to be used in cancer therapy under certain conditions. I would default to simple things that you can get in the health food store: MCT oil powder. And then you have ketone salts, which are beta-hydroxybutyrate. You could administer as a salt. KetoStart is one. There's the free acid of beta-hydroxybutyrate, although that's one of the first things we tested. And I think there's some supplement companies came out with it, but really you want the salts because you like to get the acid reducing buffering effect of the electrolytes, and that can help out. So I get a lot of questions about exogenous ketones, and I do think they are a very powerful way. I've seen people with a GKI of 5 or 6 do nothing but add exogenous ketones and then be able to maintain a GKI of 2 just by supplementing 2 or 3 times a day exogenous ketones. And if you look at their insulin levels, it's normal. I consume like the highest tolerable dose of a ketone salt, like 2 packets of KetoStart. And then an hour later, pricked my finger and measured insulin, and there was nothing. And then I administered our ketone ester, and then I measured insulin, and I saw that it popped up. It popped up only from like 3 to 6, but that pulse of insulin could activate cancer. It's not doing you any good, I think, even though your ketones are high. And also, if you consume a ketone ester at a dose that elevates your ketones, whenever you get a delta of 2 millimolar or more, that's releasing insulin. So what happens is you consume the ketone ester, your ketone levels pop up to like 3 or 4 millimolar. And then 2 or 3 hours later, your ketones are back down to baseline and maybe lower than baseline because the insulin is going to reduce your hepatic ketone output. But 3 hours later, you're hypoketotic and hypoglycemic, and then that can trigger a headache. And if you see, there's a couple clinical trials that came out with like 1,3-butanediol. They're selling it as a ketone ester, but it's really not a ketone ester. If you esterify that to ketones, then it's an ester. And I don't want to confuse people listening to this because it may sound highly technical, but I think the important thing is that I think ketone esters are powerful. They need to be more safety work needs to be done in the context of cancer, and that there are significant advantages to using ketone electrolyte salts, and that people should not fear salt. They should not fear sodium. They should not fear calcium. They should not fear magnesium. These electrolytes are beneficial. They help buffer your blood, and they have very favorable effects, like in general.
Earlier, I asked you about ketones and the possibility of fueling cancer. As you're talking there, it got me thinking about the specific benefit of having ketones in the body, in the blood, as a cancer patient. And you gave some really great nuance there of ketone esters and to stay away
Yeah.
from those until further research, at least when it comes to cancer. And you gave
Or
good
or
options with
smaller
the
doses
MCT.
too.
Okay.
Yeah.
You got into the nuance there, and I think that was really, really important. And then we know we can still do the MCTs or the ketone salts. But what
Yep.
I'm getting at with all this is what is the therapeutic benefit? We know it's going to change the ratio of the GKI when we have exogenous ketones. What are they doing specifically to cancer?
Yeah, very good question. So we design all our experiments to test the question, is it carbohydrate restriction associated with a ketogenic diet, or is it the ketones themselves that actually had the therapeutic effect? And one of the first publications we published in American Physiology Journal was on what's called central nervous system oxygen toxicity, or CNS oxygen toxicity. And hyperbaric oxygen is something that I'd like to talk about too. But when you go inside a hyperbaric chamber, or let's use the context of a Navy SEAL using a closed circuit rebreather, when he dives down to 50 feet on 100% oxygen and gets down to 2.5 atmospheres or below, then that oxygen can trigger a seizure, a grand mal seizure. And so we have a model system in the lab where we replicate this in rats. And I was highly skeptical that giving exogenous ketones could mitigate oxygen toxicity seizures. So work was done by the military to show that if you fast 24 or 36 hours, but for a rat, that's like me fasting like 3 to 5 days, that increases the latency to seizure more than any anticonvulsant drug. So this really inspired me to go down that path. I was like, let's do the ketogenic diet. The military was like, no, we're not going to give a high fat diet, but we'll fund like a ketone ester. We want the ketogenic diet in a pill. So I tested beta hydroxybutyrate monoester. I tested 1,3-butanediol. It had no effect. So I was thinking, okay, keto adaptation needs to happen before you get the anti-seizure effects. You really need to suppress insulin. But then I worked with a chemist. His name is Patrick Arnold. He's got a Wikipedia page. You can read about him. He's a brilliant chemist, but I couldn't get the molecule that I wanted to synthesize in academia. So I was able to get it synthesized, and it was a molecule that elevated beta hydroxybutyrate and acetoacetate more or less in a 1-to-1 ratio. And I was given the recipe by Dr. Henri Brunengraber, who ran the NIH metabolomics core at Case Western. So I got the recipe, we synthesized it. I gave it the monoester of acetoacetate and it's a 1,3-butanediol acetoacetate monoester, and then we made the diester. Then this worked remarkably well. The animals were consuming a high carbohydrate rat chow. We gavaged, which means we tube fed them 30 minutes prior to 5 atmospheres of oxygen, which induces a seizure pretty quick, like 5 minutes. And then when we gave them the ketone ester, they were in the chamber for like an hour. And actually we went to 90 minutes, which then you start to get pulmonary oxygen toxicity. Like it's almost like we couldn't give them oxygen toxicity. It was actually energizing and stabilizing neurotransmission And it had such a neuroprotective effect, it was almost hard to induce oxygen toxicity seizures. So this made me realize that independent of macronutrient manipulation, we could administer a ketogenic agent, not all ketogenic agents, but this specific ketogenic agent, and it has, an anti-seizure effect. So then, I mean, you're asking about the effects on cancer. So we actually formulated various diets, and one of the studies we published in the International Journal of Cancer. Dr. Angela Poff was the first author on that. And I think the title is Ketone Supplementation Decreases Metastatic Cancer in a Metastatic Cancer Model, or something like that. So if you just Google ketone supplement, metastatic cancer, ketogenic, it would come up. And it's open. We paid for it to be open access. So when we integrated the ketogenic agents, in this case, it was 1,3-butanediol. And we also did 1,3-butanediol acetoacetate diester, which had a little bit more of an anti-cancer effect, but they both did. And we fed that to the animal, then they lived longer. It increased their, the duration. It decreased tumor growth, and we had an enhanced survival. And then we also directly added ketones to the media of brain cancer cells that we were growing. And we looked at proliferation. And so we saw less proliferation, and we saw more cell death in the brain tumor cells that we grew in the presence of like 2 millimolar beta hydroxybutyrate. And so beta hydroxybutyrate by itself can decrease glycolysis. Beta hydroxybutyrate has anti-inflammatory effects. Beta hydroxybutyrate has epigenetic effects through class 1 and 2 histone deacetylase enzymes that could further boost endogenous antioxidant capacity and make our healthy cells more robust. And there's probably an antioxidant component to the redox status of the microenvironment of tumors. And then there's the epigenetic effects directly associated with beta hydroxybutyrate. So I think it's multifactorial, and what we say pleiotropic effects of ketones. So I think it's a number of different things working in synergy. And it may also be due to changing the energetic source of the mitochondria. So when the mitochondria are burning the ketones for energy or deriving ATP, from them, the mitochondria produce proportionally less superoxide anion. So superoxide anion then gets converted to hydrogen peroxide. And then in the presence of like free iron, you can drive something called the Fenton reaction and produce hydroxyl radical. And then that creates an environment that can fuel cancer. You can damage nucleic acids, membranes, and things like that. So you have, and you ask about ketones. What are ketones directly doing? And I think they're doing many different things. They're altering the redox state of the cell. They're changing the bioenergetic capacity. They have profound anti-inflammatory effects. So we published a paper in Nature Medicine. And that paper, Dr. Deep Dixit from Yale was the first author on that. And he had studied the NLRP3 inflammasome in the context of fasting. And then some of the data that came out of that study showed that beta hydroxybutyrate was very high, and that correlated with the NLRP3 inflammasome suppression. So I actually gave him the supplement and generated the diet for a further study that got published ultimately in Nature Medicine in 2015, I think, that showed that simply feeding food with ketone supplementation suppressed the NLRP3 inflammasome to a similar extent that fasting did. And that NLRP3 inflammasome, when it's activated, sets off a cytokine storm of various, IL-1 beta, for example, IL-6, TNF alpha, and other things, but mostly IL-1 beta. And these things can drive the tumor microenvironment in a way to drive metastasis and invasion. And even if you don't have cancer, the NLRP3 inflammasome can drive the initiation of healthy cells to cancerous cells. And the NLRP3 inflammasome is tightly linked to radiation necrosis and damage, downstream damage from radiation. So all these different things could be factoring in to the patient. Not only the lowering of glucose and suppression of insulin and associated signaling like IGF-1 and mTOR, but the elevation and sustained elevation of ketones has cellular protection effects and also anti-cancer effects.
Let me give you a hypothetical situation to try and understand this in a practical way. Say you have two cancer patients and they both have the same GKI. One is facilitating that with either MCT oil or ketone salts, and they're having a little bit more carbohydrate in their diet, versus somebody that's doing it strictly dietary. How do you feel about the two different outcomes?
It would be important for both patients to measure insulin. And interestingly enough, and not only me, but when I added carbohydrates back in to my diet, which I do now, I keep almost 100 grams of carbs. When I went from like 25 grams of carbs to 100 grams of carbs a day, but kept my ketones elevated with a ketone salt throughout the day, I felt better. And then I was like, well, I was kind of curious about my insulin level, and then my insulin level went down when I more than doubled my carbohydrates, but actually kept my ketones, elevated a few times throughout the day. And I was very curious about this, and I've had a number of reports. I am positive that if you do a study on, with a large group of people, you would see the same thing. And I think what you're seeing is that when you add a little bit of carbs back in, it's reversing some of the physiological, non-pathological insulin resistance. So simply adding a little bit of carbs back in can actually improve insulin sensitivity in some way, because it gets pyruvate dehydrogenase complex, it gets GLUT1 transporter, it sort of reactivates and initiates the glycolytic pathway and sustains that pathway. On a strict ketogenic diet, you're basically cutting off that pathway. So insulin's kind of like absent and it's not doing its job. But if you titrate a little bit of carbs back in, then your body's always hungry for carbohydrates. And then insulin starts to work a little bit better, because that's the case for me as a healthy individual, I think. So my insulin was cruising about 4.5, and then I added carbs back in, and I did it for a month, and then I did it again, then it was 3.3, and I was like, oh, that doesn't seem right. And then I did it again, and it was like 3.2. I was like, oh, that's really interesting. And then I took some time off, went strict keto again, because I feel great on strict keto, but sometimes like I lack a little bit of that drive when I do powerlifting or I'm working really hard. And then I did an insulin test again, and I'm back up to like 4.2 or something, which is still great, right? But it's suggesting that maybe a high fat ketogenic diet, independent of weight loss or maintenance, basically I'm just maintaining my calories, is producing a mild state of physiological insulin resistance. And I think in the context of a ketogenic diet, maybe that's favorable because the insulin resistance is pushing your body to more fat oxidation, right? So like your body's like glycolytic pathways are suppressed, and the body's like, okay, maybe we just need to release a little bit more insulin to kick up these glycolytic pathways. But then that is not working because you're just not giving glucose as fuel. So you're just making glucose through the backbone of the triglyceride. So, I mean, this is all like, if a physiologist was listening to this, they would say, yeah, that would probably make sense. And it's just a lot of speculation, but I think there's good scientific rationale behind some of these observations. And I think it may be, so if we're talking about the context of the cancer patient, I think a carnivore diet can work. Paleo Medicina, that group in Budapest, Hungary, have done some remarkable work with cancer patients. We flew to Budapest, we met with them, they showed us the data, and I'm convinced that a Paleolithic ketogenic carnivore diet is therapeutic for cancer. They convince me of that. And I'm kind of a bit of a skeptic. So I do think a carnivore diet can be effective for that. But I also think that there are benefits to including a wide variety of plant-based compounds like, broccoli, cruciferous vegetables, and various colorful salads could make up, and you could get 50 to 75 grams of essentially fiber into the diet, and that could be beneficial. I do think fiber is overrated. I do well without it. If I get fiber in the morning or the afternoon, it doesn't agree with me. So I just like backload all my fiber at the end of the day, typically in the form of like maybe an avocado, a little bit of broccoli, and blueberries.
I want to make sure I understand what you just said there about seeing this new data.
Yep.
When it comes to cancer, if you were diagnosed, would you go to a carnivore diet given what you've seen? Or is there additional benefit from getting, you talked about some plant compounds there too. So I'm just curious,
Yeah.
what way would you go given what you know right now?
I think for people who have food allergies and for people who are willing to adhere to it, simply eating meat, liver, fish, beef, things like that are uh, can be therapeutic. And I think a lot of the positive results happen because the carnivore diet's preserving muscle mass. And it's also controlling appetite in a way that creates a caloric deficit. And by virtue of creating a caloric deficit, you are suppressing the hormone insulin. You have amazing glycemic regulation. There are some people who go on carnivore and their glucose goes up, but a calorie restricted carnivore diet is therapeutic from the context of a glucose ketone index.
Are you passionate about the groundbreaking and heroic research of Dr. Thomas Seyfried on metabolic therapy and cancer? So are we. That's why we've created something special for you, in collaboration with Johnny Rockermeyer, a German book publisher and translator. Introducing our collection of meticulously crafted books that distill the essence of Dr. Seyfried's work. Dive into the science and discoveries. These summary books are your gateway to understanding the intricate world of metabolic ketogenic therapy in a clear, concise, and engaging way. Whether you're new to the subject or a seasoned enthusiast, our books offer insights that can change your life. Ready to explore this transformative knowledge? Visit our website at www.cancerasametabolicdisease.com to get your copy. You can buy the ebook there directly and the paper book via the provided links. Here's the best part. A portion of every purchase goes directly to support Dr. Thomas Seyfried's groundbreaking research. That's why the direct ebook purchase is the best option to donate as much as possible. You can see all of the donations Mr. Rockermeyer has already made at www.ketoforcancer.net. That's right, when you buy our books, you're not just...
So for me, it all comes down to, what does the science say? A glucose ketone index of 1 to 3 is therapeutic. So however you achieve that, you could do a vegan diet. If you could achieve that with a vegan diet, it would be hard, but that would be therapeutic. I personally believe that titrating in certain plant-based compounds, especially if you're just cruising and wanting to do this for prevention, like, coffee, cocoa, cinnamon, turmeric, garlic, ginger, with vegetables like broccoli. I have almost a half cup to a cup of wild blueberries every day. Mixed salads here and there. Sometimes I'll go a couple weeks without having any salads, but I do try to keep broccoli as kind of a staple, not like a huge bowl, but more like a garnish on the side. And I think a little bit of fiber at the end of the day can be helpful. However, sometimes I run out of broccoli and I'll go weeks without having, and buying it. And it's like, man, maybe I feel a little bit better. So, so I'm not a vocal advocate of the carnivore diet, but for someone who's not a vocal advocate, I tend to follow it a lot. So, but I'm not one of those people that come out and like promotes the carnivore diet, but I do believe that it's a really valid option for a lot of people. I think there's a lot of benefits to it, but I am not also of the opinion that plants are trying to kill you. So I'm not in that crowd. Although oxalates, and various other plant-based compounds are problematic in people who are doing these plant-based only diets and vegan diets. There's no doubt about that. But largely speaking, I don't believe that plants are a problem, that fiber is a problem. The epidemiological data is highly skewed to the benefits of fiber. So how do you explain that?
It sounds like maybe unintentionally you've given the carnivore diet a try, when groceries run out or whatnot. But have you ever given it like a 30-day go where you've just had like meat and salt and water?
Not 30 days, but I've definitely done 2 weeks, and I did blood work after that, and my LDL and ApoB went up. So then I started just adding a little bit of carbs back in, mostly in the form of wild blueberries, dark chocolate, and a little bit of salad and broccoli. But we're talking like pretty small amounts. And then we have avocado trees, we have mangoes, on our property now. So I tend to kind of add these things into the diet periodically. But I will say when I start to feel like inflammation coming on, or I start to feel unwell in some way that I can't really explain, and I feel some things my body, if I default back to a carnivore diet, just meat and salt and water, and I guess I'll have coffee. I don't know, coffee is not carnivore, I hear, but if I default to just more of a carnivore approach, I do feel better. I have to admit that, even though I'm not like an advocate for it, I do when I'm feeling unwell, and my mind feels a little bit sharper, right? I feel like this morning, all I ate was I have grass-fed ground beef that I bought at Walmart, of all places. I gave blood last week and I got $50 card for Walmart, and I bought $50 of grass-fed ground beef because our local supplier, I ran out from that. And that's all I had this morning. I had 2/3 of a pound of grass-fed ground beef, and I feel great, almost like I'm fasted. And if I was to have like a standard American breakfast, I would not feel good at all. So I grew up, eggs and oatmeal with an unsettled stomach throughout the morning, and just kind of never figured out in my youth that the oatmeal was kind of messing with my stomach. So
Talk more about the plant-based approach to cancer because I feel like when it comes to naturally taking on cancer, if you were to do a Google search, you'd have these two camps. And at the extreme, you'd have vegans and maybe juice cleansing, and then you'd have carnivore at the other end. And
yeah,
I feel like both may have fasting as part of that regimen. But what
yeah.
is research showing when it comes to the vegan diet and battling cancer?
The Hippocrates Institute, which is here in Florida, I visited them before, and they do have good success with patients, but they tend to lose a lot of muscle, and they have that calorie restriction, sunken face kind of look, right? And I think a plant-based vegan approach works. Not everybody, but it can profoundly reduce inflammation. It can reduce insulin. It can reduce glucose just because the food that you're eating is fairly hypopalatable. So you don't overconsume it, for one thing. You get, if you do your homework, you can get the nutrition that you need. But you're typically in a calorie deficit state, and as you follow this, and what that does is it improves dramatically many different cardiometabolic biomarkers, and insulin associated with associated with cancer growth. So you're just reducing the drivers for cancer. And it's debatable, but there are compounds in plants that have anti-carcinogenic effects, at least in petri dishes. But I am not fully convinced that this is translatable. I think the major benefit from these vegan and plant-based diets are simply due that they lower glucose, they lower insulin by virtue of creating a caloric deficit. That's my opinion until someone convinces me otherwise. There are, the most compelling data, I think, is from some of the work that was done by colleagues actually at Moffitt Cancer Institute, Dr. Nagi Kumar, looked at things like green tea and other plant-based compounds, that are encapsulated through extracts. And these things can be incorporated into a normal diet. And they have, almost drug-like effects at reducing inflammation, at suppressing different pathways. So there's no doubt that there are components in plants that have anti-carcinogenic effects, but I'm not sure you would get them at, the high concentrations just by eating a vegan diet. But you can get extracts of various things like EGCG. So EGCG may actually work well with the metabolic approach to cancer because it tends to bind up and reduce glutamine in the blood. So some studies show that extracts of EGCG could lower glutamine by like 15 to 20%. So that could be favorable. So yeah, I would not. I think an ideal approach could be a plant-centric ketogenic diet. And many patients come to me and say, I do not want to eat animals. And sometimes you can talk them into a vegetarian approach where they just incorporate eggs and maybe a little bit of dairy. But I don't think there's anything in particular beneficial to a vegan approach. And of course, there's the Budwig protocol, and there's lots of different, websites and people that promote it. But I don't think there's anything in particular that would be, for me as a metabolic scientist, it really comes down to metabolic physiology and the glucose ketone index. That's not to say that you can't incorporate many of these plant-based compounds into a ketogenic diet, and then you get the best of both worlds, right? So do your research, and there are books written on this, and I don't, go into it. I have them, I've researched it, and I have various protocols that kind of I share with others on that. But I think everybody has different opinions, and I don't want to promote it too much because some of these plant-based compounds can interfere with standard of care therapies, including radiation or even immune-based therapies. So I don't feel like it's good to over-promote them. I do think many of these things are great for a preventative approach.
So we've talked about keto, carnivore. We've went to the other end of the spectrum into the vegan diet.
Yep.
The other area I'm curious your thoughts is somebody straight up water fasting. And right away, as I say that, what pops into my head is when you're talking about cachexia and losing too much weight and losing muscle mass. And I do want to touch on the exercise piece and using that as an adjunct to metabolic therapy. But how do you feel about water fasting?
If someone's BMI is 25 or over and they engage in resistance training and they're not afraid to eat adequate protein, meaning 1.5 to like 1.8 grams per kilogram, then I'm for it. That's a lot of criteria there. But I am for water fasting, especially in the context of going in for chemotherapy. So, and Walter Longo has, done his fasting mimicking diet, but there's good research on fasting prior to chemo as a means to reduce side effects and then to augment the cancer killing effects of chemo. So that's beneficial. Also, from the metabolic approach, a comprehensive metabolic approach could incorporate hyperbaric oxygen therapy, which reverses tumor hypoxia. When you hyperoxygenate a tumor and reverse tumor hypoxia, the oxygen produces proportionally more superoxide anion and then the hydroxyl radical we talked about, mostly because of the free iron associated with the breakdown of various heme proteins that drives the Fenton reaction. So you have oxygen specific effect within the tumor where it creates a scenario where the tumor cells are selectively vulnerable to the oxygen killing effects. And some of the early observations that we made in cancer cells is that if I had primary dissociated hippocampal neurons or primary dissociated cortex neurons and I hit them with oxygen, a certain level of oxygen, they were more or less okay. I could see that they're under stress because I measure intracellular calcium and I measure oxygen free radicals. But if I do the same protocol to glioblastoma cells or various cancer cell lines that we have, I noticed that that level of oxygen would kill them. And when I ended up measuring using dihydroethidium and then mitosox, a mitochondrial reactive oxygen species dye, I saw that the mitochondria are producing this big burst of oxygen free radicals. So that gave us the idea to look at hyperbaric oxygen. And surprisingly, giving hyperbaric oxygen to animals that were not on a ketogenic diet didn't really do much. There was trends for decreasing tumor growth. But when we coupled the ketogenic diet with hyperbaric oxygen, then we saw a nice additive, borderline synergistic effect to that. So that maybe I steered us a little bit off path, but I thought it was important to kind of mention the hyperbaric oxygen because I know a lot of people are doing it. And I guess what I wanted to say is that if you fast prior to doing hyperbaric oxygen, that would definitely make it less likely that you would experience oxygen toxicity seizures or CNS oxygen toxicity. So that is clear. I mean, because you're basically giving your body a neuroprotective anti-seizure therapy. And then you're also suppressing insulin, lowering glucose, and elevating ketones while you're blasting the tumors with high pressure oxygen. So you're kind of crippling the tumor's ability to defend itself by reducing the pentose phosphate pathway, which is the cancer's ability to make glutathione. So you're kind of, it needs to do that. It needs like sugar and glutamine to do that. So if you enter into chemotherapy or if you enter into hyperbaric oxygen therapy in that fasted state, that could be beneficial. But I would warn people against doing too much fasting, especially if you are not physically strong and carrying some excess body weight. So even if you're normal body weight, you just have to be careful with doing too much fasting and really appreciate, for me, what I tell patients is let your physical strength be the gauge. Like if you could do a certain amount of push-ups, if you go to the gym, if you could lift a certain amount of weight, and your strength is more important than muscle when it comes to outcomes, but I mean, the both are important. So you should be able to maintain a certain level of strength throughout your protocol. With metabolic-based therapies, typically the patient comes out the other end in better health. And that can't be said for the standard of care therapy. They come out kind of, pretty awful shape sometimes. But what metabolic therapies and things like fasting can do is mitigate a lot of the damage that standard of care therapies can do.
I'm glad you brought up that piece of fasting with chemotherapy. That's what I was getting at way earlier in the conversation. I was trying to highlight that piece where it can help with chemotherapy being more effective and helping with symptoms during that treatment phase. I'm glad you went into hyperbaric oxygen. I wanted to get into that for sure. So for somebody that wants that to be more effective, you mentioned the fact that fasting or keto diet is going to be helpful. If somebody wants to bring on hyperbaric oxygen as an adjunct to metabolic therapy, and again, they're either fasted or they're on a keto diet, how often would be the sweet spot of doing that? Like a certain number of times per week? There's a lot of variance there. Yeah. Is it just one time is enough, or what? How can you do it too much?
Very good question. We do not have the data for me to even speculate on that. What we do have data on is there's 14 different FDA-approved applications for hyperbaric oxygen therapy, and one of them is radiation necrosis. So if you are a patient and you've had radiation therapy, your insurance will cover hyperbaric oxygen therapy. So this is like I've communicated with many patients who have done this. And I was going to the hyperbaric, the Association for Hyperbaric Medicine, and also the undersea UHMS, Hyperbaric Medicine, society, where different clinicians would be presenting on this, even when I was like, a graduate student, and I didn't have any interest in cancer, but I was like, wow, that's really, they would show like radiation necrosis, and this patient had terminal cancer, and like, by the way, the patient's still living. And it's like, whoa, that's that. So it was like a seed was planted in my mind. It was like, oh, was it oh, so they got radiation therapy and they got the standard of care and survival's like 5 or 10%, and they just happen to be an outlier, and that's interesting. And I saw this kind of over and over. Uh, so the seed got planted that hyperbaric oxygen therapy could be beneficial, and work done in our lab, and this is sort of validated by not too many people, because not too many people have hyperbaric chambers with like microscopes inside them, or different electrophysiology, patch clamp, things like that, and even a scanning laser confocal where you can optically section the mitochondria and look at. But it was very clear that oxygen had a far different effect on cancer cells than it did on healthy normal cells. And it was someone at the Moffitt Cancer Institute that reached out to me and said, I want to talk to you about the hyperbaric oxygen. And his background was hyperbaric oxygen and from the context of hypoxia, tumor hypoxia, but also brought to my attention that the efficacy of radiation therapy was proportional to the PO2 of the tumor, meaning that as a tumor grows, it becomes hypoxic. And if you direct radiation to the tumor, it's very difficult to kill that tumor because the radiation needs to basically strip off the electrons and generate reactive oxygen species to kill tumor. So many people think that radiation damages cells by creating double-stranded nicks in the DNA, and that creates, mutations and kills the cell. And that does happen, but directly, but the 80% of the ability of radiation to kill cancer cells is through the generation of reactive oxygen species. It's not directly by like the radiation beams itself. It's by the radiation induced increase in reactive oxygen species. And that does not happen if the tumor is hypoxic. So if you reverse tumor hypoxia and oxygenate the tumor and then apply radiation, then the radiation becomes like super effective, right? So this is an idea that I had, and it just hasn't been implemented. It's very logistically difficult to do that. But one thing patients can do is, if they have a hyperbaric chamber nearby, is get hyperbaric oxygen therapy, and oxygen stays partially elevated in the tumor even when you get out. And we also know that the reactive oxygen species that are generated from the hyperbaric oxygen stays elevated for hours, if not like a day or more after, right? So if you were to couple that, either have chemo or radiation before or after hyperbaric oxygen therapy, or just do it on the same day, I think that would be beneficial. And, and if you're getting radiation, right, it's going to really help the radiation necrosis. That's like clear. That's an FDA approved application. But you may be able to augment the therapy by coupling the two together. Of course, you could further enhance it by, in a fasted state, if you go into that therapy, both of those approaches with a GKI of 1 to 3, then you're really giving yourself a benefit for a better outcome.
Two more areas I want to touch on before we part ways. One of them you recently touched on a little bit, but I want to go deeper into. And that was when you talked about the EGCG from green tea and that impacting glutamine. We've gone deep into the
Yeah.
GKI and approaching starving cancer from that aspect, but we need to make sure we acknowledge the glutamine piece too. And I asked Dr. Seyfried when we were chatting one of the times if there was any natural way of controlling glutamine, and he didn't have one for me. His method is to use the pulse of drugs to pulse that over time and to attack it that way. What I'm getting at with all this, what other natural products besides the EGCG or different natural things we can do, maybe it's exercise or who knows what, you'll know better than me, but what ways can we attack the glutamine naturally?
Yeah, I mean, a lot of work still remains to be done in this area. Just a couple things that come to mind. Creating a caloric deficit, preventing excess protein consumption, so just meeting your protein needs but not eating beyond that. This will lower blood levels of glutamine. There's data, it's not super strong data, but I mean, there is data to show that EGCG extract can reduce glutamine to some extent. Um, and then there are a couple, of course, Dawn is one of the drugs that Dr. Seyfried uses. And there's no doubt that Dawn is going to decrease glutamine use by the tumor. It's a very powerful glutamine antagonist. It does have some side effects. So a drug that I think that could be used, it's prescription, but does not have a whole lot of side effects. We've done some work in the lab, but not really. It's just more like cell-based assays. Another drug is sodium phenylbutyrate. So it's sold as buphenyl for urea cycle disorders. When you consume this drug, the metabolite conjugates with glutamine, and then you pee glutamine out. And then, you could look at various studies. It can knock glutamine down, I think, down to 30%. Maybe one study was 50%. But it's having a mild reduction of glutamine effect, and it's kind of dose related. The dosage does have to be a little bit high. It comes in a powder. I've taken it. I've done blood work. It didn't seem to alter, my comprehensive metabolic panel, liver or kidney function at all. I was curious of it. There was a study that was done in a glioblastoma patient at Moffitt, and I don't know whatever happened to the patient, but a glioblastoma patient used sodium phenylbutyrate, went into remission, and it was like there's like 5-year scans with no tumor. And it was the first author was Baker, and it was published in like 1999 or something. And I've tried to find this person or the team that did it, and they just went on. I guess they were doing the residency, but that got me very interested in sodium phenylbutyrate. So and I delved more into the research, and people have sent me 2 or 3 dozen papers on sodium phenylacetate. In mice, it's hard to use sodium phenylbutyrate because there's like an enzymatic deficiency that would prevent its therapeutic efficacy. But sodium phenylbutyrate also functions as a histone deacetylase inhibitor. And that was the reported mechanism, I think, in the Moffitt case report. So it's having a bunch of different effects. And just one of the effects that I found out later on was that it could lower, serum levels of glutamine. So that's one. And then the drug Dawn, I think, has a tremendous potential. And I just haven't been able to incorporate that into the research that we do, because I still want to nail down, and optimize the protocols that we're working on. Even the diet, I mean, taking a step back, I think we still have a lot to do in regards to optimizing the fatty acid composition of the diet, and optimizing the protein source and the needs, and optimizing the microbiome. But no doubt, for us to basically have the optimal approach to managing cancer, we do need to address the glutamine topic.
And when it comes to glutamine, how much do we need to knock that down? And how often? And again, this is
Yeah,
probably something that still needs to be researched and teased out. But in your opinion, how
yeah.
hard do you have to hit that?
This was discussed at a cancer conference. So if you bring this up among oncologists or cancer biologists, they would say, well, that's a bad idea. I mean, glutamine is given to cancer patients that undergo chemotherapy. Oral doses of glutamine help to restore gut function, and the delicate gastromucosal lining of the gut takes a big hit with chemotherapy. So typically cancer patients are given glutamine. It's a conditionally essential amino acid, and it's given to burn patients. So the vast majority of oncologists and cancer biologists will say you don't want to restrict glutamine. Glutamine's a really important amino acid, conditionally essential. When you get a burn, your immune system goes haywire to because you compromise your immune system with this, when you break the skin open, and also when you undergo chemotherapy. So glutamine plays a very important role as a fuel that's important for preserving your immune system and immune function. And if you lower glutamine too much, then you're compromising your immune system, you're compromising your gut. and you're potentially altering, different neurotransmitter systems and other, you're weakening your body. So it's much like chemotherapy is, taking a poison with the hopes that you're, you know, sparing your healthy cells to the degree that you can stay alive while you're killing the cancer cells. And I think the same thing can be said for these glutamine antagonists. They are toxic. Uh, Even drugs that we're interested in that target glucose, like 2-deoxyglucose. 2-deoxyglucose is a glycolytic inhibitor, 3-bromopyruvate, lonidamine. They inhibit hexokinase 2. They're remarkable drugs that we're able to kill. What's very interesting is that some of the early studies we did with brain tumor cells, and we didn't, it would have been interesting to do Dawn with this, but we had brain tumor cells that we dropped the glucose level and we put in ketones, and then all the cancer cells would die. And if we had hippocampal neurons or cortex neurons and we dropped the glucose level and threw in ketones, the ketones would preserve the health, preserve the survival of the neurons. So it was a very dramatic demonstration. It kind of it replicated some of the work that was reported previously by a guy at University of Florida. And I just wanted to see if this was like, replicated, if we, because I kind of didn't believe it. And it's like, wow, okay, cancer cells need glucose to survive. If you give them ketones, they die, in the absence of glucose. And that's not the case with primary dissociated neurons, at least in a petri dish. So there are drugs too that could kill the cancer cells. 2-deoxyglucose, lonidamine, 3-bromopyruvate. But much like Dawn, it's going to be, the dosage is going to be really important, right? With 2-deoxyglucose, it becomes cardiotoxic. Above 25 milligrams per kilogram, I think, is safe. It's actually used for epilepsy as a ketogenic diet in a pill. And I think it's kind of expensive drug, and as is lonidamine and some of the other ones. But I mean, I think of glutamine targeting and these glycolytic inhibitors as like the icing on the cake once you've nailed down everything else. So, you try everything else and you try to gently manage the tumor, but I feel that they have the real capacity to do more harm than good, much like radiation and chemo under certain conditions, right? So I think they need to be done. Well, more studies need to be done. A lot of studies have been done, actually. They're just not the big, RCTs that we need. But I think these things have potential, and I think they need to be used very cautiously. Not by cancer patients should not be finding these things on the internet and self-administering them. I think they need to work very closely with a doctor who has experience using them in patients.
Got it. We've touched on the exercise piece, but we'll end on this. For somebody that has cancer, they want to use exercise as a modality to enhance whatever protocol they're going through. What type of exercise is best? How often? Because again, it's always a dose thing too. You don't want to over exercise. And then what impact are we looking for on the physiology by doing that?
Yeah. Well, I think to answer that, anything that a patient is willing to do, and it depends on the patient, just simply getting out and walking. If you could walk, and you do a couple miles every day, morning and night, after meals is a good thing to improve your GKI. And then if walking's easy for you, you might try rucking or you might try jogging. With resistance training, I love body weight exercises. You don't have to go to a gym. Lifting weights, the big major exercises like deadlifts and squats and like bench presses are great. Like the staple exercises are great. I like to do them and get a lot of bang for your buck. But push-ups, chin-ups, dips, Pilates, yoga, yard work, anything, do, just get your body moving. I'm a big fan. I think one of the biggest life hacks that you could do is getting a pet. Our dogs ensure that I do a morning walk and I do an evening walk, after their meals. I mean, it's just like they keep you on schedule. Apparently they help your microbiome, just by, the things that they bring in from the outside. And I think most importantly, from our perspective, is that they provide psychological health. They're just like a stress relief. So exercise has tremendous metabolic benefits, preserving muscle, but exercise is also an important tool for psychiatric health too. And I think I could probably speak as a graduate student that was stressed out all through grad. So I self-medicated, by lifting weights and working out. I didn't take it to much extreme, but if I didn't do it, I felt like I was having withdrawal symptoms from like a drug that was anti-anxiety drug or something like that. So it was a very good stabilizing. And I think the diagnosis and then the whole treatment paradigm of cancer is incredibly anxiogenic, anxiety provoking. And exercise is an extremely effective way to mitigate a lot of it gives you a sense of control. You feel better, you release endorphins, and most importantly, we know that it's improving outcome. And I think it needs to be talked about more. And I should probably be talking about exercise more. And we should probably be researching it more. It's just hard to research it in our model systems, but a very important component.
You talked about the anxiety there, and I can only imagine the anxiety that somebody experiences when they're diagnosed with cancer and has to navigate, all the different information out there and to continue, possibly working and keeping the family moving forward. And there's just so many aspects, and this just adds a whole big dimension to ruffle things up. So what I'm getting at with all this, somebody that's tuned into this point, I think what would be helpful is to have some sort of coach or clinic they could go to that follows what we're talking about today, or even a book or other resources. Because I there's a lot in there, because I know there's different aspects, having a clinic versus a book to do more research. So let's break that apart in two. Are there clinics out there that people can go to for metabolic therapy? And then two, what other, you mentioned, I forget his name, tripping over the truth earlier, but other resources people can dig into to learn more about this?
Yeah, Travis Christofferson, a good friend and author of Tripping Over the Truth, has Care Oncology. So people can just Google Care Oncology. And I think one of your former guests, Maggie, knows Travis, and I think might be working with Care Oncology. So I have compiled a lot of resources on ketonutrition.org. So maybe, just include that in the show notes if you have them. Including dietitians who have decades of experience working with patients. Miriam Kalamian is one of them, has a great book, Ketogenic Diet for Cancer. Denise Potter, she works very closely with Beth Zupakania, who's worked in the field of epilepsy for like 3 or more decades. These are people who know the science and the art of ketogenic diet implementation. Of course, their bandwidth is kind of limited, but they are creating online educational platforms that could be a resource for patients, but more importantly, they're training practitioners to be able to take this and then guide patients. But I've compiled a lot of this on ketonutrition.org. You click on the resource section of that. And when it comes to like oncologists, we need a field of, like, I guess you'd call it metabolic oncology, right? Where doctors are open to, I don't like to use the term alternative, but to integrative approaches, to integrating metabolic based therapies. And that could be, of course, nutrition, supplementation, exercise, and cancer specific metabolic drugs. And there's a whole toolbox of like at least 24 of them. I'm working on a document now. It's like, and that could include, plant-based compounds too, but like, pharmaceutical drugs can be repurposed. So we need that field to advance. And maybe, the federal government is funding a small amount of clinical trials, but I think what we need is an entrepreneur or a philanthropist that can kind of step up and fund some of the RCTs that are needed to understand the dosage and the timing associated with these protocols, and just understanding the diet. And then every patient is different, and then I do feel very strongly that different cancers are going to respond differently. And we put the majority of our focus on, we studied some breast cancer models, but we put the majority of our cancer focus on glioblastoma, brain tumor, and metastatic cancer, because in those two scenarios, the standard of care doesn't really do anything. So it's like, why don't you start with the most aggressive forms of cancer, and then whatever protocols we develop, if it works for these cancers, then it's probably going to work for other cancers that have similar metabolic phenotype, which is the Warburg phenotype, highly glycolytic, highly metastatic, invasive, tend to be more responsive to these therapies.
All right, Dom, we're going to link up the resource you mentioned there. We're going to link up your website, your social media. And I just want to thank you for doing the work you do, coming on the show and sharing this information. This is going to be such a great resource for people to dig in and start to learn about this, quote unquote, like you say, alternative approach to cancer. And I just want to thank you again.
Yeah, I'd like to say integrative approach to cancer.
Exactly.
Yeah. So when you approach the doctor and the oncologist, ideally with an open mind to these things, to nutrition in general, you want to not really mention alternative therapy, mention an integrative approach, because in many cases, I feel very strongly that these approaches will synergize with what is being offered in the oncology clinics. And if it's the case of, metastatic cancer or glioblastoma, ask the doctor to give you evidence that survival outcomes will be improved with whatever therapy is being offered to you. I think that's important. And if the evidence is not there, then you may want to, question the use of certain chemotherapy radiation protocols, because I've observed that it could decrease the life expectancy and even the quality of life of patients. So just something to think about. But I'm not against it. I'm just of the opinion that you need to question the doctor when it comes to standard of care. But we're all about, I'm in this to create a therapy that can be used with standard of care therapies.
All right, Dom.
So I just want to make that clear, that it's not an alternative to the standard of care, but something that can work with the standard of care. I think it's a very important message.
Perfect. Thanks again, Dom.
Thank you, Jesse. Thanks for having me.